Hello, I'm Professor Morie A Gertz. I'm a consultant at the Mayo Clinic in Rochester, Minnesota, and I'm here to review with you the diagnosing of ATTR transthyretin amyloidosis. Amyloidosis is a multisystemic disease. It can cause cardiomyopathy, peripheral neuropathy, carpal tunnel syndrome. Inherited amyloid is autosomal dominant, so you usually can obtain family history when the patient inquires. The commonest manifestation are cardiac, including arrhythmias, atrial fibrillation, AV block, heart failure due to cardiomyopathy. The peripheral sensory neuropathy is the second most common. It's both axonal and demyelinating. It's length dependent and it is symmetric. Asymmetric neuropathy would not fit with amyloidosis, and it is progressive, ascending, beginning in the feet, then calves, then knees, then upper extremities and fingers become involved. Autonomic nerve failure also occurs, can cause orthostatic hypotension, nausea, vomiting due to pseudoobstruction, intractable diarrhea, alternating with constipation, anhidrosis, as well as sexual dysfunction. Bilateral carpal tunnel syndrome is very common, half of patients. Vitreous amyloid is seen with specific mutations. It is a very broad multisystemic disease. When we look at the presenting symptoms, unfortunately, they're very nonspecific. Dyspnea, fatigue, edema, dizziness, which hardly bring amyloidosis to mind, although may bring to mind heart failure or chronic obstructive pulmonary problems. Over half of the patients also have some degree of peripheral neuropathy or carpal tunnel syndrome, an important ancillary clue. The typical tests that result in a diagnosis of amyloidosis include biopsy or aspiration of the subcutaneous fat, endomyocardial biopsy, magnetic resonance imaging with its characteristic late gadolinium enhancement, rarely rectal or renal biopsy, and increasingly used to make an accurate diagnosis is pyrophosphate scanning of the heart. Diagnostic delays in this disease are common. The median time to diagnosis is 2 to 3 years, but in one study, it took 10% of patients over 6 years to come to a diagnosis. And I'm certain that in earlier years, many patients died of refractory heart failure without an accurate diagnosis of amyloidosis. For hereditary ATTR amyloidosis with neuropathy, the mean time to diagnosis is 4 years, and over that period of time, significant functional loss and neurologic disability increase occurs. 45% of patients who have hereditary ATTR amyloidosis report misdiagnosis initially, and it's everywhere. Idiopathic carpal tunnel syndrome, idiopathic polyneuropathy, Sjogren's syndrome, heart failure, spinal stenosis, gastroparesis, plantar fasciitis, fibromyalgia. In addition, some patients with hereditary ATTR amyloidosis will be diagnosed as amyloid, but will be misdiagnosed as immunoglobulin light chain amyloidosis and receive completely inappropriate chemotherapy because the different types of amyloidosis were not accurately distinguished from one another. In terms of the diagnosis, ideally a tissue biopsy is helpful. The common tissues that are biopsied to find amyloid deposits include the subcutaneous fat, skin, lip, salivary glands. Endoscopic biopsies will reveal it. Bone marrow will reveal it. You can see amyloid on the sural nerve biopsy, on tissue removed at the time of carpal tunnel release. And of course, if necessary, an endomyocardial biopsy is 100% sensitive. The gold standard for the staining of tissues for amyloid is Congo red with green birefringence observed under polarized light. But in the last 5 years, a new diagnostic algorithm for ATTR amyloidosis has been developed that does not require a biopsy for a diagnosis of cardiac amyloidosis. Using the myocardial tracer, pyrophosphate, or DPD, patients who have ATTR amyloidosis will typically have increased uptake. And if there are no laboratory features that would suggest light chain amyloidosis, such as a monoclonal protein or an elevated free light chain, you can make a diagnosis of ATTR amyloidosis based on the imaging studies without a biopsy. When a biopsy is present, it is important to classify the type of amyloid protein. The most common techniques that are used are immunohistochemistry to diagnose the amyloid protein subunit, and more recently, the use of proteomics by using laser capture mass spectroscopy to sequence the peptide and identify the protein. All patients who have ATTR amyloidosis require genetic testing to be sure that the TTR molecule is not a mutant form of TTR, because the treatment today is different for mutant TTR amyloid and wild type TTR amyloidosis. This is an example of pyrophosphate bone imaging in patients with cardiac amyloidosis. I'll start with D. D is a control patient, and you can see that the tracer takes up in the skeletal muscle. And if we focus on the thorax, you can see the sternum, thoracic spine, and ribs, but no evidence of cardiac silhouette. With hypertrophic cardiomyopathy, once again, there is no uptake seen. You can see the bones of the thorax, but nothing else. But in both hereditary TTR amyloid and wild-type TTR amyloid, in addition to seeing the sternum and the ribs and the spine, you can clearly see outlined the entire left ventricle, which shows as black, and below you can see tomographic studies that demonstrate that the tracer is not just in the blood pool of the left ventricle, but is actually in the heart muscle itself. And this, in conjunction with the absence of a monoclonal protein, is diagnostic of ATTR amyloid, and these patients become candidates for therapy. So here's a relatively simple algorithm on how to proceed in patients who are suspected of having TTR cardiac amyloid. First, you do the imaging, which in the United States is PYP, and in Europe is DPD. And if there's no uptake at all, grade 0, TTR amyloid is very unlikely. And you would do immunofixation of the serum and urine and free light chain. And if it was positive, you would do cardiac magnetic resonance imaging and then seek a diagnosis of AL amyloidosis if positive. For patients who have grade 2 to 3 uptake, if the patient has no monoclonal protein, you have a pretty firm diagnosis of TTR amyloid, and you can do genotyping to distinguish mutant from wild type. If there is a monoclonal protein present, though, you may have a patient who has TTR and or AL amyloidosis, and those patients usually require histologic confirmation and mass spectroscopy to identify the specific subunit. The most difficult are patients who have grade 1 myocardial uptake. Those patients usually require referral to an amyloidosis treatment center. Whether they have or have not a monoclonal protein, they may indeed have either light chain or TTR amyloidosis, and specialty evaluation would therefore be highly recommended. This is just a review of some of the tools that are used to diagnose amyloid. Obviously, clinical suspicion is the most important. And increased clinical suspicion can be seen by echo, which shows infiltrative cardiomyopathy with diastolic dysfunction, magnetic resonance imaging, which shows thickening of the heart walls with late gadolinium enhancement, pyrophosphate or DPT scintigraphy, which, if positive, is very strong evidence of TTR amyloid. Elevation of the BNP would be a nonspecific marker of heart failure. In terms of making the diagnosis early, I would recommend scintigraphy. It's non-invasive, quite inexpensive, and it's quite specific for TTR amyloidosis. For evaluating treatment response, we find that echocardiography and MRI are helpful. The level of the brain natriuretic peptide is important. It's considered a response if it goes down by 30%. The 6-minute walking test is currently being investigated for its utility in evaluating response to the diagnosis. Functional evaluations are best done with imaging, either by echocardiography, looking at diastolic parameters, global longitudinal strain, ejection fraction, and by MRI. So now let's talk about these patients that we previously discussed. A 68-year-old male with proven neuropathy who progresses after 1 year and is referred. The patient saw a hematologist, was misdiagnosed as AL amyloidosis, was given a trial of lenalidomide and dexamethasone, which is typical AL amyloid treatment, and failed. Patient then developed orthostatic hypotension and diarrhea due to autonomic failure, and again was treated symptomatically, lost another year, lost 8 kilograms. Patient sought a second opinion. A skin biopsy was performed. It underwent laser capture mass spectroscopy. Amyloid deposits were seen and sequenced as TTR. Genetic study showed V50M-TTR mutation, the most common mutant amyloid seen worldwide. Our second patient had a small monoclonal G-kappa protein in the serum. And this patient was seen initially by the cardiologist because of lower extremity edema, which was not diagnosed. When the neurologist who diagnosed this patient's peripheral neuropathy found the monoclonal protein, the patient was diagnosed as distal acquired demyelinating polyneuropathy, a subset of chronic inflammatory demyelinating polyneuropathy, was given 3 months of plasma exchange, got worse, then received intravenous immunoglobulin for a year and got worse. Patient went back to the cardiologist because of progressive edema and dyspnea on exertion. An echocardiogram was read as consistent with amyloid. The patient had a pyrophosphate scan that was strongly positive for TTR amyloid, and genetic testing showed a S97T mutation. And so this patient had familial amyloid polyneuropathy and cardiomyopathy with a monoclonal gammopathy of undetermined significance. And it was that point that it became clear that the family history was consistent because his father died of heart failure and had some problem with ambulation during the last 2 years of his life. So I'd like to summarize by telling you that ATTR amyloidosis mimics many, many other diseases and should be considered with idiopathic cardiomyopathy, hypertensive cardiomyopathy, hypertrophic cardiomyopathy, as well as patients who present with idiopathic peripheral neuropathy or CIDP. Diagnostic delays are typical, but early suspicion can lead to early diagnosis and life-saving therapy. There are diagnostic tools such as DPD and pyrophosphate scintigraphy that will arrive at a rapid diagnosis. And although this disease previously was invariably fatal, it now can be treated in all of its forms, and survival has been shown to be benefited. I wanted to thank you for your attention. This is my Twitter feed in case you'd like to contact me with any specific questions or want to discuss any of your patients. Thank you very much for your attention.